one of the potential biggest influences that will happen in this value-based care scenario will be the consolidation that's taking place in the industry. And there seem to be a lot of opinions on both sides. That consolidation will drive increased value, and there clearly is some early evidence that consolidation is decreasing value by increasing cost. So, Ted, I know you've waxed in on this poetically quite a bit, that the consolidation, at least in some aspects of the healthcare economy, is increasing cost. It's not creating more value. So let's start it off there, and we'll see if we can get a counter opinion.
Yeah, I'll look at it. I think there's a couple different ways of looking at it, and I'll defer to Mike to talk about consolidation on the payer side. But if I look at consolidation on the healthcare side, and especially in oncology, there is no doubt it's costing more. If we look at studies by Moran, Milliman, Avalier, go right down the list, and most recently Milliman, it shows the higher cost to both the commercial side as well as Medicare when oncology care consolidates into large hospital systems, and especially with 340B. Why does it consolidate into those big systems? Because if you get 100% margin on drugs, it's the gift that keeps on giving. It is literally the pot of gold at the end of the rainbow. And the problem is when it consolidates in, it's not only the private payer that's paying more, that's actually the intermediary in a lot of cases for the primary payer, the employer, but it's basically, and it's Medicare, so it's the taxpayers, but it's patients directly. So why do you see more calls coming in and getting your phones off the hook, ringing your phones off the hook, is because patients are struggling. It's remarkable to me when an oncology practice is acquired by a hospital that the patient comes in who's in active treatment, and they're coming in they go in for their second cycle, the practice is acquired, they go in for their third cycle. Now, they're seeing the same oncologist, the same oncology nurse is giving the drug, the same name is over the door, and it's the same building, and basically they get their bill, their EOB, and they say, what? This cost me 50%, 75% more, because there are all these other charges, and I have no idea, because it's now under the hospital's billing system. And so I think we have an inherent problem. I know a lot of people say that, oh, there's more coordination of care, it's better care, it's higher outcomes, therefore it's justified. But I think the problem right now is it's clear the consolidation. And by the way, Bruce, this is not just in oncology. There have been study after study after study that the consolidation is basically costing the payers and the individuals as well as the taxpayers more.
So you would think that there's kind of this methodology where hospital systems want to consolidate, which gives them greater leverage in their ability to control price, particularly with payers. They can't do it as much with the government. Now, payers would want to consolidate because they could have more leverage and control with what they're going to pay for, let's say, pharmaceuticals. And so, Ira, it would seem to me that in a way that behooves society in the long term, because we got an ASP calculation, and if you can, as a payer, drive down costs, then that drives down ASP, which is going to benefit society in the aggregate, because now Medicare, which can't negotiate directly, benefits from your negotiation. Now, do I have that wrong?
No,
Ted says I do.
Yes, it's
well, that presumes you can negotiate around an ASP-based reimbursement environment, which is
it's more complicated than that.
Well, it's because you've got 50% of the hospitals that are 340B. So if you look at ASP, and ASP plus 6 going down to ASP plus whatever, or even ASP going down, Bruce, because of that thing, because you take a smaller practice that may have a higher ASP off the market, it basically goes down. What does that compare to a hospital that basically is getting, has literally 100% margins on their drugs? It's a blip. They don't care about that. This is you have to realize with this 340B, and by the way, I'm not demonizing it, because on the federal grantee side, the community health clinics, the Ryan Wright, AIDS clinics, you take 340B away and literally they close. They are dependent on it, it has to stay. But on the hospital side, I heard of a hospital who walked into a practice and physicians made the administrator go out, leave the room, and said to the physicians, 340B hospital, okay, how much will it take to get you to come over? I mean, this is what's happening because this is big business with that. So I think we have to realize is that consolidation is really having some big unintended consequences, and it's not dependent on ASP fluctuating a little bit, or ASP, the government wanting to cut it from 4.3 to 2.5 to 0.86% in this new experiment. But it literally has to do to, you're talking about a huge cushion on these drugs. And what's ironic about it, if you think about when you were practicing, Mike, this is just like AWP, but we've injected steroids into AWP. That's what the problem is. We've gone back to that system on the hospital side.